Hello there students, this is Kamran Bhopal and I'm back here again today with question and answer session for the station Recurrent UTIs. This is preparation for the ST3 Urology National Training Numbers. We have done a video already on the recurrent urinary tract infection history, but we will go over a few questions that they may ask in this station. The first question that they may mention is, I didn't mention the examination within the recurrent UTI. Within the abdomen, I would look for predisposing anatomical causes such as loin tenderness, palpable kidney or bladder. I would then perform a PV and a speculum exam with a chaperone and look for any leak, and then I would finish my examination by doing a complete neurological examination. Most of the examinations are pretty similar, especially in outpatients. There's some differences here and there. For example, in stress incontinence, you can use the Oxford grading scale to look for pelvic floor strength, etc., etc. But as far as you know the basics and you've done a systemic examination, that should be okay. After that, they may ask about investigations. So investigations wise, you would do a urine dip, a microscopy, culture and sensitivity, and a bladder scan. You would also do renal function test, infection markers. You would ask for a frequency volume chart or a bladder diary. Can be done to rule out bladder underactivity or outflow obstruction. You can also mention, obviously, a flow test and post-ward residual. And then imaging wise, we can suggest an X-ray KUB or a ultrasound KUB to rule out structural causes. In elderly patients, people who've got visible hematuria, you can consider flexible cystoscopy. Even patients who are having recurrent UTIs and there's persistent blood on that and they're in the elderly age group, you can do a flexible cystoscopy. But it's not always done. Then a question about what is recurrent UTI. So recurrent UTIs is 3 urinary tract infections in 1 year with a documented history that every episode has been treated. Or it is 2 urinary tract infections within 6 months with each of the urinary tract infection documented and completely treated. So this is the definition of a recurrent UTI. What else can they ask? There is a question people do get confused about. What is the difference between bladder diary and a frequency volume chart? I had a lot of read through in different papers, and the Abrams classification 2002, which is the widely renowned classification, basically suggests frequency volume chart records the time and volume of voids, whereas a bladder diary records the time, the volume of voids, and also any other relevant symptoms such as urgency, incontinence, and number of pads. And also bladder diary consists of noting what is the intake and what the patient is having, such as tea, coffee, etc., in addition to just the volume of voids. Then what are the factors which identify UTI as complicated? The FRCS Viva book is quite clear on this. So any structural or functional abnormality of the urinary tract or UTI in the presence of underlying disease, which increases the risk of acquiring infection. So these are the 2 reasons. You can also give examples. Structural and functional abnormalities, so catheter, stent, nephrostomy, stones, obstructive uropathy, ileal conduit. There's so many structural causes, but these 2 are the headings that you have to mention. Then you can say some examples on top of that. And UTI in presence of underlying disease, you can say, for example, diabetes mellitus, immunosuppression, multiple sclerosis, neurological disease. Then what conservative advice you can give to the patient in recurrent UTIs? Increase fluid intake, symptomatic relief with bicarbonate of soda, D-mannose and cranberry juice over the counter, avoid bubble baths, wash genitals after sexual activity, before and after, and topical estrogens if there's poor estrogen status. And then the alternates of antibiotics include D-mannose tablets. So D-mannose tablets come as 2-gram powders or tablets and needs to be taken daily for 6 months. It prevents bacterial adherence to the urothelium. And the World Journal of Urology 2014, if you want to know, you don't have to mention this. 2014 RCT suggested lowest recurrence rate of UTI, which was 15% as compared to no prophylactic group, which was 62%, and nitrofurantoin group, which was 21%. So 15% with D-mannose tablets, which was the lowest, which is pretty good. Then you've got Hiprix, 1 gram twice daily for 6 months, and that is methenamine hippurate. It converts into formaldehyde and hippuric acid. So formaldehyde has got the antibacterial function, and the hippuric acid makes it acidic, the urine, and prevents UTI. Then number 3 is bladder installations, which is with cystistat, which is sodium hyaluronate, which helps with restoring the gag layer, and usually it's given once a week for 6 weeks, and it causes 70% improvement, and if it works you can continue it for 6 months, once every 6 weeks. So that's how you're given that. Now there's some additional things as well which will give you brownie points. So Urovaxome, these are basically vaccinations which primarily have E. coli strains, but some of them have 4 strains, some of them have more strains than that. But the commonest gram-negative organisms you're vaccinated against, and they seem to be quite effective. They're not readily available in the NHS, but are available in the private sector. So it's something good for brownie points if you want to mention. Then they can change this scenario if they give Klebsiella or Proteus as an organism which is being grown, and then they change the scenario into a Staghorn calculus scenario, that an ultrasound KUE shows a Staghorn calculus. What will you do moving forward? Then what is the role of antibiotics in recurrent UTI? So there's 3 ways they can be used. Self-start therapy, so a 3-day course initiated as soon as you develop symptoms. Post-intercourse prophylaxis, and low-dose long-term prophylaxis. So these are different ways they can be used. Then what is the treatment of a Staghorn calculus? If they go in this detail, you must say that this is something extra that you can say. So according to the Blandy and Singh paper 1976, the mortality and morbidity was significantly high in the patients whose Staghorn was not dealt with surgically. And henceforth, the Staghorn calculus should be treated surgically unless the patient is not fit for anesthetic or surgery or refuses treatment. So this is an important one, because in Staghorn calculus you don't really have room for conservative management, and you have to look into surgical options if the patient agrees and they're fit for anesthetic. So that's about it for recurrent UTIs. Also have a look at my video which I will be posting later down the line with extra questions. So these are mostly questions which I picked up from different online sources, but towards the end of these videos you'll find extra questions, and those were actually the ones when I did interview courses, the extra things that were told. I put them together separately in one of my notebooks, and I will be going over them as well. So all the best, and I'll see you next time.